welcome to pneumonia. So you should get very familiar with pneumonia, especially the pathophysiology and treatments and everything that goes along with it, because pneumonia is going to be the #1 reason why you're seeing most of your patients in the hospital, whether it's to prevent a post-operative pneumonia or let's say someone had broken ribs and they're trying to prevent ultimately a pneumonia. Or you have someone that has lung disease like COPD who's very prone to pneumonia. So pneumonia is going to be a very common thing. Even with pediatrics, you're going to see those pulmonary infections that happen that cause a pneumonia. So when we're looking at all these disorders, so now we've already covered the major obstructive disorders. So everything else in this course we'll talk about being restrictive, and pneumonia is actually a restrictive disease. So everybody thinks, okay, mucus, a bunch of mucus plugging up the airways, that would be obstructive. No, that mucus is not what's significantly plugging up the airways. This is a massive inflammation that's going on in your respiratory zone. Now there is red blood cells and alveolar capillary membrane and leukocytes and a bunch of stuff like that going on that can reduce diffusion of oxygen into the bloodstream, which makes their oxygen levels lower, which one of the #1 things for treatment of a pneumonia is oxygen. Now oxygen won't reverse pneumonia, right? It's not therapeutic in the fact that it will reverse pneumonia, but it will help give you a higher A to A level, which allows for better oxygen, more oxygen to enter the bloodstream. Because your diffusion's poor in your respiratory zone with pneumonia, the extra oxygen will allow it to get into their bloodstream. So pneumonia can have a lot of varying presentations depending on the patient's baseline health. And so you should get very familiar with this, but in general, pneumonia is a restrictive disorder. You have this massive inflammation that's going on in the respiratory zone. We're not talking about large airways. We're not talking about transitional zone. We're talking about small airways, your respiratory zone. And so that massive inflammation, you have a bunch of red blood cells, white blood cells. You have a bunch of stuff that's making it hard for oxygen to get into the capillaries, right? You have this massive blocking that's going on. So we're creating a big issue of getting oxygen from here into that capillary that surrounds the outside. And we're having all this fluid that's just filling up and going through these pores of Kohn back and forth, canals line bare, and it's making it very, very hard. And so different pneumonias have different severities, so we'll get into it here. All right, anatomical alterations that you're going to see with pneumonia. Some people will call it pneumonia or a pneumonitis. And we'll get into that when we talk about like aspiration pneumonitis, right? This is with consolidation, which means there's a bunch of fluid and mucus and stuff there, is usually the result of inflammation. Inflammation that affects the respiratory zone. So this is a sort of an important bullet point here, right? So pneumonia is a consolidation where it's caused by an inflammatory process that affects your respiratory zone. We're not talking large airways where a bunch of mucus plugs could happen. We're not talking about transition zone. We're talking about small airways that are inflamed and causing an issue getting oxygen into the bloodstream, right? So as a result of this inflammation, you're going to have a bunch of serous fluid and some red blood cells that will pour into the alveoli. You're going to have this stuff sort of diffuse into the alveoli. So just like an injury or anything else where you're going to have fluid that diffuses into that area, same thing's going on here. Something abnormal is going on in the lung tissue. So the body's trying to heal itself by sending red blood cells, white blood cells, all that stuff in there to sort of heal it. So that's a response to help heal the lung tissue. Leukocytes, those friendly white blood cells, will also move to the infected area, right? What's their goal? Well, they want to kill any invading bacteria on the alveolar wall. So this is a normal response. This is a healthy response. And so usually you're looking at pneumonia being secondary to an infection most commonly. So the idea here is to either prevent someone from getting an infection that would cause a pneumonia, or if they already have a pneumonia, how do we become more helpful to the body in dealing with this infection? How do we support them? Things like oxygen, airway clearance, things like that, that we'll talk about here. So you have your type 3 pneumocytes, your macrophages, that also will move through those little pores of Kohn, those neighboring alveoli, and they'll move to that area of infection to help remove any bacterial debris. So they're going to do their little phagocytosis thing where they go and eat and help manage that infection. If the infection is pretty widespread or overwhelming, the alveoli become filled with a bunch of fluid, right? We're not talking about the transition. We're not talking about the main airways. We're talking about the respiratory zone just being filled with a bunch of fluid, right? You're going to have red blood cells. You're going to have leukocytes. You're going to have macrophages. When this happens, this is what causes that consolidation that you will see, that radio opacity that you will see on an X-ray. So here is the slide. I took this from your book. This is looking at a bacterial pneumonia, and this is just a microscope view. And you're looking at exudates. So transudates and exudates. Exudates are usually higher in protein, and they're mostly white blood cells, or sorry, neutrophils, that you're looking at here. And so they're surrounding the alveolar wall. So this is going to be, here, let me pick a color that's not. Here's the alveolar wall, right? But outlined in yellow. So they're going to surround the alveolar walls and have capillaries that are congested and dilated. So that's these capillaries that are congested and dilated. So they're mostly filled with red blood cells, because remember, in an area of injury or infection, the body will send a lot of red blood cells there to help give it nutrients, to help heal, to help get white blood cells there too, to help kill off infection. So this is an exudative process. An exudative process is very typical for a bacterial infection like pneumonia. So this would be like a bacterial pneumonia, not a viral pneumonia, but a bacterial pneumonia. And so what's going to happen with this person is all these white blood cells will be in this site trying to eat all these areas of bacteria, and eventually this is going to cause what we see usually with this yellow purulent, so pus-like yellow sputum that usually you see with a bacterial pneumonia. Now, does that mean you can have a yellow sputum and have a viral pneumonia? Absolutely, but typically that's a sign of a bacterial pneumonia, just in general. The cool thing here is the structure of the alveoli is maintained, so we don't really have as much of an issue with the integrity of the alveoli when it comes down to this. Usually there's not too much destruction unless we get into one of those pneumonias that are necrotizing, where they eat away and destroy tissue, which I think we already talked a little bit about a necrotizing issue, but there are necrotizing pneumonias. And I believe we talked about it in the bronchoscopy section, if I remember right. So usually pneumonias don't cause a lot of residual issues, or residual destruction, I should say. So there's not a lot of damage just with the pneumonia here and there. They're usually expected to make a recovery. It takes a while, but they're usually expected to make a recovery. But the big issue here is if we have someone that has COPD, that obstructive lung disease, or let's say we have someone with cardiac disease, they're going to have a lot harder time with dealing with this infection. And so that's where things get complicated. So if you have a patient in the hospital, right, mentally put yourself in your Pima scrubs and your Pima stethoscope, you're in a hospital, and you're getting reports that you have a patient coming in that has pneumonia or probable pneumonia, and they have COPD. Well, that's going to be a more complicated process for them. they might have to require something as high of a support as mechanical ventilation because their lungs may not be healthy enough to deal with this infection like someone that has absolutely no underlying pulmonary condition. So that's one of the things with COPD education in people with lung disease or cardiac disease is avoiding infections is going to be a big benefit to them because their body's ability to compensate when they do have a pneumonia is going to be very diminished. Their ability to compensate is going to be very poor if they get this condition. And so when you have a pneumonia on a healthy 24-year-old, otherwise healthy 24-year-old, I should say, that's a whole different story than if you have someone that has COPD that gets a pneumonia. They might require totally different levels of support, and that's where you should start to look at some of these things here. This can even be life-threatening for some of those conditions. So you got to be up on your pneumonia therapies and understand if this patient has baseline cardiac, baseline autoimmune, baseline pulmonary conditions, that this can be a very serious and life-threatening issue. So this is not just, oh, I have a touch of pneumonia, I'm going to be okay. For these patients, this pneumonia can lead to life support. So you got to be very cognizant of that when you're looking at, does this patient have any underlying conditions where this pneumonia could be life-threatening, right? And that's where you can choose your level of aggression when we're starting to look at therapeutic interventions as well. Anatomic alterations that you see with this, there are 3 of them, so remember this for a future slide that you might see, like, hey, what were the 3 major anatomic alterations, right? That's what you're looking at here. You're going to have a massive inflammation of the alveoli, so it gets very, very thick, right? A lot of inflammation, alveolar consolidation, so we'll just draw some like red blood cells, white blood cells, all that good stuff in there. And then as a result of all this stuff filling up with fluid, you're going to dilute that thing called surfactant that's in your lungs, which will eventually lead to the alveoli collapsing. So you have atelectasis that goes along with pneumonia. So like I said, this is a restrictive problem because is this thick inflamed alveoli going to want to expand very easily? Absolutely not, right? It's thickened, it's inflamed, it's swollen. Swollen tissue is not very malleable, right? And so it's not going to want to stretch. So their lung compliance is going to be low. It's going to be stiff. It's going to be very hard for their lungs to expand. And what's going to happen is their elastance is increased, which means the alveoli are going to even be more introverted than what they usually are. And so that's going to lead more towards atelectasis and alveolar collapse ultimately. So now you have alveolar collapse. You have the walls of the alveoli being inflamed and thickened, and now you have a bunch of fluid that's just sort of sticking around in there. This looks like a breeding ground for that infection, that warm, dark, humid environment just to breed and get worse and worse and worse. And that's why one of the best things we can do with patients that either have pneumonia or are prone to pneumonia is hyperinflation therapy as well, right? Help reopen those areas of atelectasis and get that going. So those are the 3 structural changes. Those are things that you'll see with this as well. And your AC membrane relationship is also way off here, because remember we talked about this in pulmonary AMP. If this is the alveoli and the capillary, normally these are in contact with each other, but since there's an infection, that lymph tissue that surrounds, that's in that loose space, remember we talked about tight space being the connection between the two, the alveolar and the capillary, the alveoli and the capillary, this lymph tissue expands and pushes the red blood cell, or not the red blood cell, it pushes the capillary away because these are swollen, that lymph tissue is swollen. It actually pushes the capillary off of the alveoli, and that can actually reduce the ability, obviously, to get oxygen into that bloodstream and CO2 out of that bloodstream. So, right, so that's where we see blood just getting shunted, because remember, we have perfusion here, without ventilation, so that's actually a shunting process. So I'm getting ahead of myself here, but you can sort of see that this is sort of a big issue in the respiratory community. So pneumonia, whether we're treating it or preventing it, it's a very serious issue. So let me ask you this. I had a patient come into the hospital, or I went to go see him, and he came into the hospital with a history of he broke some ribs. And he was on room air. He didn't require any oxygen, and he said he didn't have any breathing difficulty, and the trauma doctors ordered breathing treatments for him. And he asked, why do I need these? I'm breathing just fine. I just hurt to breathe. Well, when you hurt to breathe, let me ask you this. If you had some broken ribs right now, would you want to take a deep breath? Absolutely not, right? And so when you're looking at that, you're going to be more prone to things like atelectasis. Well, if you have atelectasis, that means you're not expanding that lung tissue, which means whatever bacteria that normally your lungs would clear, they can't clear as easily. And now that atelectasis is culturing that bacteria that should be cleared out. Now that bacteria is in there culturing and growing, and then it can cause a pneumonia, right? And then you're going to stay in the hospital a lot longer, right? So the whole goal here, and that's what I had to ultimately talk with this patient about, is educating them that the idea is to prevent a pneumonia while you're in here. You may feel like you're breathing fine now. That's great. Let's keep it that way. And when you're ready to get discharged home, you'll be ready to go. You won't have to stay in any longer because you developed a pneumonia. My goal is to keep you off of oxygen. My goal is to keep you from getting pneumonia. If it doesn't happen, I did my job, right? That's what we're looking at here. So preventing pneumonia, especially after general anesthesia, when all the cilia are impaired, right? Your ability to clear secretion. So now you have the higher chance of secretion staying deep down in that warm, dark, humid environment and developing pneumonia. That's why getting the cilia up and running after general anesthesia is a good idea, right? Active, being mobile, like walking, things like that actually improve ciliary motility, the mucociliary escalator. It makes you breathe deeper, which helps you get rid of secretions a lot more effectively. So it's a huge deal whether we're preventing it or treating it. It's a big deal, and you will spend a lot of your career dealing with pneumonia. All right, there are three types or three subcategories of pneumonia. You have your bronchopneumonia, your lobar pneumonia, and your interstitial pneumonia, and that's what we'll go into next. All right, so bronchopneumonia, this is just going to show a very patchy pattern. Usually it's just going to be in a sort of segmental area. It's not going to be widespread, just sort of in a segment, and it's going to be in the respiratory zone. Remember, parenchyma is just another word or synonym for respiratory zone. This involves both lungs and is seen more often in the lower lobes. Keyword there, of the lung, right? And in adults, if you got a kid that's like 6 months old or less that spends most of their time on their back, that's a whole separate case where you might actually see it mostly in their apices, but we're talking adults here, so I'll leave it there. Mostly the lower lobes of the lungs with bronchopneumonia. Lobar pneumonia, very widespread. It's not limited like you had with bronchopneumonia. This one's widespread. And then it has alveolar inflammation, consolidation. Usually this is bronchopneumonia that advanced and became lobar pneumonia. So you start off with a little bronchopneumonia, and then it spreads and it becomes a lobar pneumonia, right? And so this is what we see for more of your long-term bronchopneumonias. It goes to a lobar, so it goes to a whole lobe of a lung, right? So you got like the right lower lobe pneumonia or left lower lobe pneumonia going on here. So it went from just sort of being isolated to now it's went to a whole lobe. And then now, if that's left to fester and grow, you're going to develop into an interstitial pneumonia. It's very diffuse. It's all over the place. It's usually bilateral. Usually involves the septa, right, and interstitial spaces. So now it's gone into that respiratory zone and caused a massive amount of inflammation of the septa, or the little walls between neighboring alveoli. So this is usually a lot of viral pneumonias will cause an interstitial pneumonia. Mycoplasmas and then viruses obviously can cause an interstitial pneumonias. So take a guess which one COVID would be. All right, that interstitial pneumonia, right? That viral pneumonia is a big thing. When we were taking care of swine flu patients, that's a viral pneumonia. It was a big thing that we had to look at there. It was that big inflammation that was mostly the respiratory zone, and we had to deal with that viral pneumonia, and it looked very different on the x-ray. And then I think in one of our other lectures I showed, in the x-ray lecture, I showed pictures of a bacterial pneumonia and a viral pneumonia side by side, so you can see that difference. So please go back and reference that x-ray video on x-ray evaluation is, I believe, the title, and that should help you sort of clarify what you're going to see the difference when you actually look at these x-rays. There is a difference in the appearance of a viral pneumonia versus a bacterial pneumonia. A little bit difference in their pathophysiology, but definitely etiology for sure. Interstitial pneumonias can cause permanent damage. So this is the severe form of it. So broncho, mild, lobar is moderate. When you get to an interstitial, it's the severe form, and it can cause damage. Usually it will resolve without consequences, but if it's very severe, it can obviously cause some permanent damage in patients where it is very severe. All right, so this is a picture that I took from your book. Yes, I hope you are looking at it. So letter A up on top here, this is a bronchopneumonia, and it's where it's just showing it's limited to just the segmental bronchi and then a little bit of parenchyma there. So there's just a little bit of areas here and there that are affected by this issue. Letter B, when you get down to there, and now you see that that whole left lower lobe has that issue, so therefore it is a lobar pneumonia. And lobar pneumonia is usually when we talk about x-rays, and what you might see is when you're looking at the fissure and you can actually see a fissure on an x-ray. Remember, that's not normal. It is not normal to see a fissure on the x-ray. When you can see a fissure, that means either something's in between the two lobes, like a pleural effusion has developed, or air has developed in between the two fissures, like a small pneumo. Or it could be that this area down here is so atelectatic, so consolidated, that it's just highlighting that separation between the two. And that's what you might see here. So one of the things you might see on the x-ray could be a fissure for a lobar pneumonia, right? And that's something that we'll talk about a little bit when we get to the x-ray. So this is a lobar pneumonia. A lot of diffuse alveolar infiltration here when you're looking at this. And usually this is the end result of a bronchopneumonia, right? So this starts at A, and then we advance to letter B stage. That's if it's, doesn't get cleared up by the time it gets to that whole lobe stage. All right, when we're looking from one segment to another, that's when the whole lung can be filled up, and then that's when ultimately, if that's not treated, it can go into an interstitial pneumonia, right, where it's just widespread and massive. And a lot of the patients that you'll be taking care of will either be in letter B or letter C category. A lot of people in letter A category may not require hospital care unless you're looking at someone that has a pre-existing cardiac or pulmonary disorder. That's when you might see letter A's come in, right? So C is that interstitial pneumonia where it's usually diffuse, it's widespread throughout the lungs, and it's more with your mycoplasma pneumonia or viruses. So this is most likely when you're going to see these patients is usually with a mycoplasma or a viral pneumonia. So bacterial pneumonias usually don't spread too far beyond a lobe, and they can, but when you're looking at excessive widespread interstitial pneumonias, that's usually going to be your virus or mycoplasma pneumonias that you're going to be taking care of. And that's what makes one of the dangerous things of a viral pneumonia is because it is so widespread. It can make such a big difference in how severe it affects the lungs, and that's why viral pneumonias we get really concerned about. with people compared to the bacterial pneumonias typically in a lot of cases. Pneumonia terms, I put this in here just for your benefit. You'll hear people say, oh, I had a double pneumonia, right? This is actually not a medical term, so not a medical term. And so if you hear people say this, that means the doctor told them, oh, both lungs were involved. I had both issues. I had bad breath sounds on both sides, right? Something like that was going on. So this was a double pneumonia. So it's not a medical term. You should not use it, but if you hear someone tell you or a doctor say or someone use it sort of as medical slang, that's what they're saying, that it was sort of more of that interstitial, that widespread pneumonia that was going on. So they were saying it was a pretty bad pneumonia, right? It was widespread, most likely viral or mycoplasma pneumonia was going on with them at that point. Walking pneumonia, this is another one that is not a medical term. So this means they had a mild case of pneumonia, so either bronchial or segmental pneumonia. But this patient was still walking around. This call it walking pneumonia because they're usually out of the hospital. They're up and walking. They're at home. They're at work. They're at school. So on and so forth. That's what they mean. They think it was a mild case of pneumonia. Okay, so just so if you hear walking pneumonia and double pneumonia, you sort of know what they're talking about, even though those aren't official medical terms. So when we're looking at hospital-acquired and community-acquired pneumonia, so they might call these HACs, HA, hospital-acquired conditions, hospital-acquired pneumonias, right? HACs or HAPs, right? These are also known as nosocomial pneumonias. Hospital-acquired or nosocomial means you caught it while you're in the hospital. That's why if a patient's healthy enough to leave, we try to get them out of there before they catch something else. These are mostly gram-negative bacilli, things like Klebsiella, Serratia, E. coli, things like that. Even Pseudomonas, staph pneumonias can easily be a big issue here that these patients can get while they're in the hospital. So let's say you are immunocompromised. Let's say you have something that gives you immunocompromisation. You have a higher chance, or you have a chance at getting a hospital-acquired pneumonia while in the hospital if there's some sort of cross-contamination or something like that going on. So hospital-acquired pneumonia or HACs or HAPs happened while you were in the hospital. You didn't have it previously. One of the things that we look at here is ventilator-associated conditions, like they used to call these VAPs, ventilator-acquired pneumonias, but the vent didn't give you the pneumonia. You just had acquired a pneumonia while you were on the ventilator. So that means you somehow had a bacteria that started to grow and breed and cause pneumonia while you were on the ventilator. So Pseudomonas aeruginosa, Klebsiella, Serratia, Staph aureus, all these things can easily be a VAP or a ventilator-acquired condition. So those are things we have to watch out for because your managers and directors of different RT departments, that's a big deal for the hospital infection rates. This is something they track. In a hospital-acquired pneumonia, one of the ways that you'll test for a hospital-acquired pneumonia is with a sputum sample or trach aspirate, right? Remember, there's a difference between the two. Hopefully you remember. But you'll get one of those and send it to culture, and after a couple of days we'll see what it's growing. If it's growing Pseudomonas, Klebsiella, or Staph aureus, then that could be a sign they have it. One of the things that we would do in our emergency department is once we intubate someone and put them on a ventilator, we would grab a trach aspirate from the patient and send it. So that gives us a baseline of what was already growing in their lungs before they were sort of on the vent for too long. And so then we can sort of see if they came in with a Klebsiella infection or if they came in with a Pseudomonas infection, then we know that they didn't acquire it from us necessarily, they acquired it from the community. Because is it possible that a patient could have Pseudomonas from a community? Absolutely, right? So just knowing what bacteria or what thing caused it won't limit it to whether it's hospital acquired versus community acquired. We have to sort of see what was their baseline when they came in. Did they get it from the hospital, or did they have it cultured in their lungs previous to the hospital? So that's why we'd get one right away, so we would know whether or not they got it from us or not. Community-acquired pneumonias, they're going to be your strep, your Staph aureus. Like I said, some of these are also a hospital-acquired pneumonia. H. flu, Haemophilus influenza, Legionella, Enterobacter. So those are your Klebsiella ones. Pseudomonas, big one as well. So how do we diagnose this? I know I'm sort of jumping here. So we have a person in the hospital we think has a hospital-acquired condition or hospital-acquired pneumonia, HAP, right? They're going to want a sputum sample or trach aspirate. And so that's how we're going to diagnose or look for this, is we'll get a sputum sample for a hospital-acquired condition. For community-acquired pneumonia, the gold standard, I would remember this, for hospital-acquired pneumonia, we get a sputum or trach aspirate. For a community-acquired, we get a chest x-ray. And I'm not making this up, I promise. So we get a chest x-ray. The x-ray looks for inflammation, atelectasis, it looks for consolidation, like a lobar, pneumonia, that's what they're looking for there, or a diffuse interstitial like viral pneumonia. So they get an x-ray to see if it's viral or bacterial, or if they already have something going on there. So community acquirers are usually diagnosed with x-ray. Hospital acquired are usually diagnosed with sputum. So let's say a patient comes in, we intubate them. Obviously, we're going to get an x-ray to verify ET tube placement in their trachea, right? Verify the correct placement. So when we're looking at that, well, one of the other things we might see is things like a lobar pneumonia. Well, that would confirm that they probably had a community acquired before they came in. So some hospitals will get that baseline sample, some won't. But just so you're aware, community acquired, the diagnostic level gold standard is going to be an x-ray. Hospital acquired, currently the diagnostic standard is going to be a tracheal aspirate or a sputum sample. Okay, so what puts someone at risk for getting pneumonia? Well, this sounds an awful lot like that whole COVID thing, right? Over the age of 65, you have a decreased ability to fight infections as you get older. Thanks, age. And so that's going to be a risk factor. That's why people older than 65, and hopefully you talked about this in your pharmacology classes, can get a pneumonia vaccine, which is pretty cool. And I think they can even get it while they're sick in the hospital. We can still give it to them, just like the flu shot. Even while you're sort of sick in the hospital, you can still get it. And so that's something that we'll look at giving these patients. They could be sick on a ventilator and get these, and it's going to help prevent them from getting some frequent pneumonias and reducing that risk there. Aspiration of secretions is a big thing. This is where we talk about a chemical pneumonitis. I like to talk about chemical pneumonitis here. So this is where they have, let's say, vomit that comes up from their stomach and goes into their trachea and into their lungs. Well, what's the pH of your stomach acid? Well, it's going to be very low. I believe it's around the pH of 3 or so in that area. So you'll have to double check me on that one. And I'm willing to be wrong, but it's going to be very, very low acidic pH, right? Your oropharyngeal secretions, not as low in pH, but it's more of that aspiration of gastric contents. And so that goes into your lungs. And so that severe acid goes into your lungs, and the pH of your lung tissue is actually more alkaline or base. So when you have an acid and a base that come together, it creates what's known as a pneumonitis. It creates a chemical change. It creates a baseline change in the pH of the tissue of the lungs, and it creates, as a result of that pH change, you're going to have a massive amount of inflammation. That inflammation in the lungs is called a pneumonitis, right? Itis is inflammation, so that's where they talk about a chemical pneumonitis, and that's what you're seeing there. And aspiration pneumonitis are very prone to causing a condition called ARDS. And ARDS is a very severe condition. Now, it's not technically a disease, it's a syndrome, But that's one of the things that you're going to see in mechanical ventilation when you guys get to that area later on, is you'll look at patients that have ARDS. Well, the number one cause of ARDS is sepsis or a blood infection, but another high cause of ARDS is aspiration. So if someone is on a CPAP or a biphasic positive pressure device like BiPAP, and they throw up into this positive pressure mask, and that vomit goes into their lungs, it can cause an aspiration pneumonia, a chemical pneumonitis that can then lead to ARDS. So we got to be very cognizant of things like that when we use non-invasive ventilation with a mask. If there's gastric contents, should we put an NG tube or an OG tube to help relieve pressure in the stomach? If there's gastric contents, right? Just to help avoid some of those issues as well. If someone already has a viral respiratory infection going on, that viral respiratory infection, so let's say you have flu B, influenza B, and you have that viral respiratory infection going on, and your system's sort of down for the count with that because it's trying to work on that viral component, you're actually more prone to develop a pneumonia on top of all this. And that's why you'll see people order bronchodilators for viral infections. Now, that doesn't mean it won't help with the viral part, but that's to help with the airway clearance and avoiding the atelectasis and all that good stuff. So viral infections, if your system's already down for the count, right? Chronic illness, we talked about this. What's their baseline medical condition? Do they have comorbidities, right? Do they have something going on that might make it so their system has a harder time fighting off infection, right? And then we already talked about this with COPD, asthma, cystic fibrosis, things like that. Is there something chronic at baseline that can make this pneumonia that much worse? And if we do have that going on, if you get report that a patient has one of these baseline conditions and they're in the hospital for pneumonia, take that serious, right? Please, please, please take that serious. It's a very serious situation when you add pneumonia on top of any of these baseline conditions. Someone has cancer, especially lung cancer, where their ability to fight off a pulmonary infection especially is going to be a hard time to do. People on prolonged bed rest. I like to stand on this podium. All right. So this is one of the big reasons why I love to see people that are up and moving. That's why I was a big fan of physical and occupational therapy at the hospital. Get these people out of their bed. And I always told you guys, and I told our physical therapist, I'm like, you guys did more for my patient's lungs than I did by giving them that breathing treatment. Because they get them up, they get them from their bed to the bathroom and back. They get them from the bed down the hallway and back. They get them to go start climbing stairs. The more activity these people with lung conditions have, the better their mucociliary escalator, the deeper they're breathing, the more effective their body's going to be at fighting that pulmonary infection. And we're not talking about making them run up and down the stairs 5 times in a row. We're talking about just getting some baseline movement that's going to help reverse some of the atelectasis. That's going to help some of the cilia to come alive. That's going to help them take some deeper breaths without us having to force them to do it. So prolonged bed rest is always a hindrance to pulmonary function as far as that's concerned. Tracheostomy or endotracheal tube, you remember you lose the protection mechanism that is your upper airway, the warm filter, heat, humidify, you lose that. And so that makes you prone for infection. That warm, heat, filter, humidify is a big aspect to that. Remember, you have tonsils, you have all these other things that are meant to sort of catch these things before they go into your lungs. Abdominal thoracic surgery, right? You'll have patients that abdominal thoracic surgery, or even I will say post-op hip and knee replacements. I'll add that in there, even though it's not in your book. But these patients that had abdominal thoracic surgery, they had their sternum cracked open for open heart surgery, or they had an upper GI issue and they had abdominal surgery. They're not going to want to breathe deep. It hurts to breathe deep. And so they're going to be more at risk for that atelectasis, right? And then what happens with this bacteria that would normally get cleared? Well, now it multiplies and grows and it causes inflammation of the alveoli, which then leads to pneumonia. So now you got pneumonia. So these people that are post-op surgeries, especially abdominal thoracic surgeries, and I'll add in post-op hips and knees because those patients aren't moving. They're in a lot of pain and they're not moving. They're not going to get up and walk down the hallway. They're not going to get up and walk to the bathroom and back. They're not going to be moving. It's going to hurt for them to breathe. They're in pain. So what do we give to people that are in pain? Medicines that make you breathe deep, or medicines that make you sort of calm down, chill out, and probably breathe more shallow. Yeah, that shallow part there. And so they're going to be very prone to pneumonia. So take those people seriously. They might be on room air. They might be on no pre-existing pulmonary conditions, right? And they just are in the hospital for a knee replacement or hip replacement. And the doctor will order nebulizers or they'll order hyperinflation therapy for these patients. Is it appropriate order? Absolutely. Because we don't want them to get a post-operative pulmonary infection. This is a huge, huge ordeal, right? The hospitals get reimbursed, and I'm not talking about money as your motivation here, but hospitals get reimbursed by what the patient's in the hospital for. And the hospital might only get reimbursed 2 days for a post-op hip surgery. And I'm just making things up here, right? They might only get replaced 2 days for that. If that person develops a pneumonia while they're in there, and they stay for a week and a half, because they developed a pneumonia, the hospital has to eat that bill. And so they're going to look at, hey, how can we more effectively treat these patients so they don't get a pneumonia while they're in the hospital? And if it was your loved one or if it was you, would you want to develop an extra infection while you were in the hospital? Absolutely not. So doing hyperinflation therapy, doing bronchodilators to get their cilia up and moving again, those are big things for these people that have low ventilation requirements, or these people that don't want to breathe deep, right? They're in pain, things like that. So that includes the rib fractures that we talked about. Immunosuppressive therapy or acquired immunodeficiency syndrome. Those are all things that can make a pneumonia that much more significant and ultimately life-threatening on these patients. That's why you have patients that are in reverse isolation, where you have to put on gowns and all that stuff before you go into the room because their white blood cells are zero because we're knocking out everything in their systems, right? Their immune system's down. Let's say they're a post-lung transplant patient, right? Their immune system is on purpose depressed or suppressed, right? So that way they don't reject their new lung or their new organ, right? Especially with acquired immunodeficiency syndrome, obviously your immune system has poor ability to fight infection. So we got to be very careful. These patients are very prone, and it can be a death sentence for some of these people. So risk factors are important. Continuing risk factors, especially when we're looking at things like the influenza, can be life-threatening to people that already have pulmonary disease, right? That's one thing that you need to be aware of. Does this patient's history matter to me? And you should say yes. Okay, this person's in the hospital for pneumonia, they're getting these treatments, have a good day. No, you need to tell me, do they have an underlying condition? Because do I need to be more aggressive with our therapy? Do I need to be more aggressive with our treatment plan for this patient, right? So if they have an influenza or a viral infection and they have an underlying pulmonary disease, that can be very, very significant for these patients. So they can turn the corner from being stable to unstable very quickly, and I hope I'm getting that across, right? So the risk of death ultimately is a lot higher in people with heart disease as well. So not only do you need to be worried about lung disease, but also do they have any baseline cardiac issues, right? Do they have any baseline comorbidities like a weakened immune system, like diabetes, things like that that can cause them to be more prone to a significant result, including death from pneumonia. So don't take pneumonia lightly. Hopefully you've gotten that bullet point from everything I've said so far. Don't take this lightly, especially if they have underlying comorbidities. Causes of pneumonia, so this is a whole separate category down here. Causes of pneumonia, bacterial pneumonias, very common out there. Viral pneumonias, that's the big one. Currently, that's in the news as I record this. Fungal pneumonia is more common with people that are autoimmune. Autoimmune issues, your system's down for the count with, let's say, a viral pneumonia. That fungal pneumonia can finally fester and grow. So usually more compromisation there. protozoal pneumonias. You could have parasites in there. You can have what's called Mycobacterium tuberculosis. Yes, so myco means it's not a fungus, but it looks like a fungus under a microscope. But it's not. It's a completely separate thing. We'll get to it. Any anaerobic organisms can cause it. Aspiration, we already talked about that, especially with secretions or food or anything can cause that. Inhalation chemicals such as chlorine gas or anything like that. And that's the one that I seen, right? I talked to you guys about that 18-year-old girl that was working as a lifeguard at a pool, and she had chlorine gas inhalation, and it caused a severe pneumonia on her, and she was coughing, like such irritation. Her irritation reflex was just going crazy. I had to give her a lidocaine neb just to sort of get her to stop coughing, so that way she could get some rest from that a little bit. But severe irritation, right? So all of these things can be causes of pneumonia. So a lot of causes there, ultimately. All right, so what do these patients look like when they show up? What do you see on these patients? So symptoms can be very different from patient to patient, right? Do they have underlying conditions? Do they have an underlying lung disease, heart disease? Do they have underlying comorbidities that can make this worse? Yeah, absolutely. If they do, then they'll look worse on presentation. Some people, a 24-year-old that got some sort of viral pneumonia, may not look too severe, right? So it's going to vary greatly. Some of it's going to be also what type of thing is causing the pneumonia, right? Is it just a little bacterial bronchial pneumonia, or is it more of a interstitial viral pneumonia going on, right? The interstitial pneumonia is going to show up in a worse or more oxygen requirement patient presentation than your segmental or your lobar pneumonias, right? A lot of times these pneumonias are going to mimic the flu or a cold. Signs and symptoms will usually develop very quickly. They're not usually over time. Like, I've had this for 3 months, right? No, it's usually going to be develop pretty quickly. So a lot of them will experience that chill, shivering feeling, high fever, sweating, right? Diaphoresis. Chest pain. This is that pleuritic chest pain, dry, non-productive cough. Remember, it's mostly in the respiratory zone, so that's why it's a non-productive cough at this point. Does that mean they won't cough up yellow stuff later on if it's a bacterial pneumonia? Absolutely not. But we're just saying they're going to have that irritant, that J receptor reflex, because that J receptors, remember, sort of in that alveolar area, that receptor area, and so that you'll sort of see that dry, non-productive cough initially. The big thing here, especially if we're looking for a hospital-acquired, is to try to get a sputum for grand staining culture. And then once we see what's growing in there, we can create a plan for treating it early on. We can know which antibiotics it's sensitive to if it's a bacterial, right? So this can help us create a game plan that can help us treat the patient more efficiently or better faster, if you want to think about it that way. So if we can get an early sputum culture and know exactly what we're looking at, not just be like, let's throw broad spectrum antibiotics at it, we're going to be that much better at treating the patient overall. So I put this in here. This is just bonus material. I will not hold you responsible for this slide whatsoever. This is just bonus material. So I put this in here as common causes of chest pain. Over here there's aortic, esophageal, lungs and pleura, musculoskeletal, neurological, and psychological disorders. And so when we're looking at chest pain, there's a bunch of different causes for it. And so if we're having chest pain in the rib area, right, it's going to be bronchospasm, it could be pulmonary emboli, it could be a pneumonia, which is what we're talking about here, tuberculosis, tracheitis, pleuritis, pneumothorax, should say pneumothorax, malignancy, okay, right, benign, right, malignancy, and then asthma, ultimately. So just having chest pain alone doesn't mean you have pneumonia. It could be other things, and that's what I'm trying to show here. Could be other things causing their chest pain. So when someone comes in and it looks like they have pneumonia and chest pain, does it mean we're not going to get an EKG? Does it mean we're not going to try to rule out other causes of chest pain? No, we still need to rule out other causes of chest pain as well. So it's just something to be aware of. Just because you have a pneumonia and they have chest pain doesn't mean they couldn't have a cardiac event currently going on, right? So just remember also, if they're hypoxic, that's going to cause PVCs and a lot of issues cardiac-wise. So there's a possibility the heart could be starved of oxygen, especially if their sats are low and things like that. All right, so at the bedside, what will their signs and symptoms be? Well, their vital signs, they're going to be breathing fast. They're going to have a lot of pain and anxiety. Of course, it's going to hurt. So bacterial versus viral, remember a low grade versus a high grade fever. So that looks like something that's important to know. How high is their fever, or how high has their fever been? Looks like something that I might ask you in the future, or ask you which is most likely the cause of their pneumonia, if it's their fever is this or their fever is that. So bacterial versus a viral, if it's a low grade versus a high grade fever. Tachycardia, the heart rate's going to be fast. Usually they'll have high blood pressure. Pleuritic chest pain, where we just talked about chest pain. Cyanosis, of course, can be present with this, especially if it's a interstitial pneumonia. Cough and sputum production, and even a cough with blood, hemoptysis, can be possible as well with this. Now, that doesn't mean every patient's going to show up with all these every time, right? It's not like that, but these are just in general what their presentation may show up, right? Usually they'll have a non-productive, like that barking or hacking type cough initially, and then as the pneumonia progresses, then it could become more and more productive. So remember, it starts off with those J receptors in the alveoli. Well, you're not going to clear that stuff right away. It's going to take time for it to move up and out of your lungs. That's what you're looking at here. And then, so that's why their cough is dry initially, and that's why they're coughing initially. They got that J receptor stuff going on in their respiratory zone, but it's not to the point where they can actually get rid of it yet. Right, so small amounts of purulent blood streaked or rusty sputum. By the time it does get out, remember the red blood cells and all that stuff. That's what you're looking at there. All right, a lot of times also you'll have an increase in tactile and or vocal fremitus. So this is when you're having that more consolidation in the lungs, means that sound transmits a lot more effectively. So this is like you have a cup, hold it up to your ear, you have someone else hold the cup up to their ear. You can talk through it and the other person will hear nothing unless there's that string that connects the cups together. So if you connect the string between the two cups, then that sound transmits better. And so that's what you're looking at here. The more consolidated the tissue, the more sound is going to be able to transmit from one area to the other. And so that's why their fremitus and the vocal fremitus, the tactile fremitus, that is all going to be increased. Dull percussion note is going to be very mute, very bass note, very low toned. Percussion note if you're doing diagnostic. Chest percussion. Breath sound is going to be bronchial because that inflammation's in there. It's going to be very deep toned. Crackles, of course, especially with atelectasis and some secretions, so you can hear both coarse and fine crackles with this. Pleural friction rub in some cases can also happen, and hopefully you guys remember going through that pleural friction rub CD-ROM in patient or the breath sound CD-ROM in patient assessment that had pleural friction rub. It sounds like two pieces of leather just sort of rubbing against each other. And obviously you can even hear whispered pectoriloquy. All that inflammation can easily cause those to show up. All right, so what will the X-ray look like? We talked about X-ray being a gold standard for community-acquired pneumonia initially. So the big three things that you're going to see is increased density. So it's going to be radio, opaque, right? This is because of all the consolidation of goo that's building up in their lungs, as well as the shutdown of tissue or the closing of tissue with atelectasis. You also have what's known as air bronchograms. So air bronchograms, this was a definition from the last class that we had. It's a area of gas pocket surrounded by either inflammation or secretions. And so that usually confirms it's intrapulmonary. And your Wilkins book, your patient assessment book, your Wilkins book in the X-ray chapter actually talks more about air bronchograms. So if you're curious and want to actually learn more, there's that section there, and that's where you would find it in your Wilkins book on X-rays and looking at air bronchograms, but it confirms intrapulmonary disease. And we're going to have areas of inflammation, right? We're going to have those air pockets, whether it's inflammation that's surrounding the air pocket or secretions and or both. A lot of these patients will also develop pleural effusions if it's significant enough. That infection, remember, is going to both in that tight space and that loose space. And so there is fluid that can build up not only inside the respiratory zone, but inside the pleural space as well. So this can not only make breathing harder because now the ability to expand the lung tissue is decreased because the alveoli is inflamed, but also the area surrounding the lungs itself could be compacted with fluid that would restrict the lungs from expanding as well. So now you got two things causing that restriction of lung expansion, both fluid and swelling of the tissue itself, as well as a bunch of fluid that's squishing the lungs. So both of those together makes it hard to breathe. So that's why these patients are going to be tachypnic. They're going to be hypoxic, and that's going to cause tachypnea on its own. But now you're going to have that extra issue of the lungs can't expand. They can't get that fluid. And so that more that fluid's crushing the lungs, the more atelectasis you're going to see, the more consolidation you're going to see. It's a massive cycle of craziness. So it can vary depending on what's causing it. So the X-ray can look normal in very, very mild stages, or it can look very severe in severe cases. But usually the increased density may involve a small segment or a lobe or one or both lungs. So we're looking for sort of how widespread it is on an X-ray. Might be patchy or uniform throughout the whole area. So if you see that cloudiness almost completely in that left lower lobe, right area, the right lower lobe doesn't look as patchy, the right upper lobe doesn't look patchy, so on and so forth. We see it mostly down here. We see it's all consolidated to the air. We might see what we see there is called air bronchograms, and that would confirm that that might be in that left lower lobe. So we're looking for a lot of air bronchograms. All right, so we're looking at this patient here. This is an X-ray of a 20-year-old female. And so take a wild guess where her pneumonia is now. Now don't answer this one too quickly. All right, let's do our A through I technique. Apices, I don't see much going on in her apices, bases. We got a good costophrenic angle on her right lung here. And then on her left lung, it's there, and it's a good angle, but is it very radiolucent? It is not. Okay. So that tells me there's something definitely going on that left lower. AB bases, good CP angle. I don't see something that would cause it to be a depressed diaphragm, so I don't see a pleural fusion. So that's good. BC is cardiac. I see aortic arch, right atrium, sorry, left atrium, left ventricle. CD is diaphragm, so let's count the ribs. 1, 2, 3, 4, 5, 6, 7, 8, 9. 9 plus ribs, so that's good. ABCDE is esophagus. She does not have an OG or NG tube. F is for fissures. I don't see anything on that left lung. The right lung, what do I see here? Interesting. So that's the right middle lobe, and lower lobe. Huh. All right. A, B, C, D, F, G is gastric. I don't see any gastric issues that would cause restriction or anything like that. A, B, C, D, F, G. H is hilar infiltration. Oh, yes. We definitely have hilar infiltration in that right lung, especially in that right lower area here. You sort of see this whole area I'm outlining, as well as this whole lobe on her left lower lobe, and you could almost see that fissure here. I should put that here. Let's use purple. Right, so you can see that fissure there between the left upper and the left lower lobe. So you're seeing a big issue there. So she's got a pneumonia. This is a severe pneumonia, especially left lower lobe, in the right middle lobes, the right lower lobes, and the right middle lobe, the right lower lobe, and also the left lower lobe. So this is pneumonia has spread. So this is going to be more of that bronchial, sort of that spread bronchial pneumonia. So this is pretty significant pneumonia overall. And you can see just from looking at it over, you just be like, oh, it's left lower lobe. But no, you can also see how patching infiltrated. And you can see these air bronchograms. Let's go to yellow again. You guys see these little like pockets of black bubbles that you see in there? Those are air bronchograms, right? It's an air pocket surrounded by either inflammation or mucus. So air bubbles that you're seeing in there. So it's definitely a left lower and a right middle and right lower lobe pneumonia going on here. So not a good case. Right, and so this is just a zoom in of an air bronchogram, and hopefully this shows up, and this is from your book as well. And you're going to see the consolidation here, and it's usually an example, and this is a staph pneumonia, but you can see how you have these airways, and you can see how these airways are inflamed, right? You can see the branching of the airways, sort of like the branching of a tree, right? And you can see these little holes. And the more you look at these, the more you'll be able to pick them up. Right? The more you see these, and you'll see all these little air bronchograms that are in here. You see all these gas pockets. That's what you're looking. Those are called air bronchograms, and air bronchograms confirm intrapulmonary condition existing, and so that means something's going on inside the tissue itself as well. That's what you're seeing here. All right, so what about CAT scans with a pneumonia? Traditionally, it's not indicated. You can see them on a CAT scan. Remember, this is the spine here, and this would be the sternum at your 12 o'clock. The spine would be at your 6 o'clock. This is the heart, so this would actually be the left lung, the right lung, right? This is the right lung, and you can see the outlining of the airways pretty darn easily with this one, right? You don't need me to point that out, but you're seeing all this consolidation, this radio opacity that's going on here, and that's that pneumonia. That's that collapsed, inflamed pus, whatever, white blood cell, all that stuff is just sort of festering and stuck in there, and that's inflammation plus fluid that's ultimately causing this. And you see these like hazy parts out here, these outskirts here, these little outside borders here that are very puffy compared to the high density that's inside. Those little puffy borders, that's atelectasis, right? So when you see it, looks like those little clouds in the air that won't produce rain, just little puffy, just nice to look at clouds that have no rain or anything like that in them. That's an atelectasis look. When you have this thick, dense, dense, very radio opaque look to it, like you see in the rest of the area here, then that's usually a sign of a massive amount of inflammation, mucus, something like that's going on. So a lot more. So all this stuff is causing peripheral atelectasis. And here are the air bronchograms, right? You can see them pretty easily here. Just dotting all over the place, right? So you can see them on a CT scan as well. All right, so if you were to do a pulmonary function test on a pneumonia patient, what would it look like? Well, remember, this is in the restrictive category, so their volumes are going to be low, right? So the forced vital capacity, FEV1, remember, is a flow rate, so it'll either be normal or increased. Remember, if you have a really restrictive lung condition, it increases elasticity. Remember, elasticity is the ability for something to snap back to its original shape. So if you have increased elasticity, in some cases, if it's significant enough, can actually cause an increase. Not something I'd worry about, but just if you're wondering why it might be increased, there you go. It's not because their airways aren't obstructed. It's because, or it opens up their airways. It's because the elasticity has increased because their compliance is low. So their volumes will be low, right? So low volumes. Their flow rates will either be normal or increased. So when you're looking at restrictives, right, volumes are low, flow rates are normal. In general, right, so their peak expiratory flow rate, all that stuff is going to be normal unless they have an underlying obstructive lung disease. Then you'll see both, right? MVV would either be normal or low. So lung volumes and capacities, take a wild guess. We talked about this being restrictive, right? We're looking at sort of that decreased overall. All right, what would an ABG look like initially on a pneumonia patient? Well, if it's very mild to moderate, just like the other conditions we talked about, respiratory alkalosis with mild to moderate hypoxemia. Remember, it's the hypoxemia when the brain gets the chemicals, when the brain gets the low PaO2 or the low oxygen levels, it's going to tell your respiratory system to breathe faster and deeper if possible. So initially, when your muscles are strong enough to do this, you'll have a respiratory alkalosis. Well, the idea here is to get as much oxygen into your bloodstream as possible. Part of that is by getting rid of CO2. So you create more parking spaces for oxygen. So you have more of a chance to have this nice looking good oxygen delivery to your tissues, including your brain, because your brain wants to save itself. So initially, in almost every one of these respiratory conditions, if you had to guess respiratory alkalosis in that mild to moderate stage. When it gets severe, when those respiratory muscles start to fatigue, you'll either see a normal ABG, right? And then even when we might get to the point where it causes a low oxygen delivery because the respiratory muscles are fatigued, we might actually have a lactic acid buildup. And we might develop an acute respiratory acidosis. So depends if they're incompensated or if they're in acute stages there. So in the severe stage, acute respiratory acidosis. If you stay in acute respiratory acidosis long enough, it will go into a combined or a mixed acidosis, right? Because now the tissues are producing lactic acid because they're not getting oxygen, so they'll go into a metabolic acidosis on top of the respiratory acidosis. That equals a mixed acidosis, right? So you'll see an acute respiratory acidosis, severe, right? And then with mild to moderate, you're going to see respiratory alkalosis. Just understand, if you see combined acidosis, that could also be a sign of severe pneumonia. Oxygenation, I love this one, and I filled it in for you. This is a shunt-like process. Remember we talked about this, right? There's blood that's going through the capillary membrane that is not going to be exchanged with the alveolar environment because of everything that's going on, that's blocking that diffusion. It's going to make it very, very hard for CO2 to get out and for oxygen to get in. So if we're blocking both of those, this is perfusion without ventilation, therefore it is a shunt-like process. Our DO2 is low because you have a low CCO2. You have a low CCO2, which means your CaO2 is going to be low automatically, because remember, the CaO2 gets its content from the CCO2. So if we can't get a good CCO2, our CO2 is going to be decreased. Your consumptions, your VO2 and your A to V gradient, those are going to be normal, right? That's how much your body's consuming. Now let's say they're running a significant fever. Say they're running at 105, right? Just making up numbers. That's where those can be increased. But just in general, those will not be changed. And then finally, your oxygen extraction ratio is increased. This is exactly because your DO2 is decreased, right? We talked about this before, right? If I have a good DO2 and I'm only taking a minimum out of there, I'm going to have a lot left over. If I have a lower DO2 and I'm taking out the same amount that I was before, I'm going to have a lot greater ratio of what was taken out. So my O2ER might be increased in this example here that I just drew on the screen. So I have an increased gradient, but nothing changed with my metabolic requirements. I still am requiring the same amount, but I'm taking out more of what I got overall. So remember, the O2ER is increased because the DO2 is decreased, and your venous saturation is going to be lower because we have an increased O2ER. All right, so what do we do with these patients? What would their lab test look like? So sputum example, sputum would be one of the first things that we can do in the hospital there. Run it, see exactly what's growing, and we can use a treatment regimen specific to what is growing. The other thing too, a lot of these will cause buildup of fluid around the outside of the lung in the pleural space. We can get a thoracentesis sample, and that can actually help. We can run that sample with labs and we can tell what's going on there. So therapeutically, someone has a pneumonia, what's going to be their intervention that we would use? Well, initially, if they're hypoxic or hypercarbic, we could use some high flow oxygen therapy or even low flow, depending how severe their condition is. But oxygen therapy is going to be one of the things here, and that's why I put oxygen therapy protocol. Some conditions, they might want you to start with higher flows because that'll help them breathe more efficiently, especially if they're working hard to breathe. Others might just want you to give them baseline, like regular nasal cannula oxygen. This kid here is on a high flow device, and you can see how large bore that tubing is. That's that Posey's law in action, because that means we can run higher flows through it. What? Physics? I love it. Lung expansion therapy especially. That's going to help reverse or help prevent more atelectasis, or help reverse or be therapeutic with the atelectasis. That will help them with their condition overall. Airway clearance as needed. Of course, bronchodilators as needed. Remember, the bronchodilators here may not be for bronchospasm. They might have a bronchospasm as a result of this. So let's say you have asthma. Let's say you have reactive airways and you get a pneumonia. You might have that pneumonia trigger a bronchospasm, right? So just be cognizant of something like that. But let's say someone doesn't have that. Let's say someone does have a severe pneumonia, and let's say they don't have a lot of secretion. So we're not using the bronchodilators for airway clearance, and they have pneumonia and they don't have a lot of secretions going on. Why would we give it? Well, is the issue in the primary airways or in the respiratory zone? It's in their respiratory zone, right? And so remember, smooth muscle lines all the way from your alveoli all the way on up through your rest of your respiratory zone. And it's what gives structure to these non-cartilaginous areas. So if we bronchodilate these areas, even though there's no bronchospasm, but we give a relaxer, we let the albuterol or we let the bronchodilator relax, what happens with the structure? It pulls it from the outside. It can make it more patent, almost like what we see here. The larger the diameter, the better flow of gas we can get to that area. So that means we might actually be able to help these patients therapeutically with bronchodilators, even if they don't have bronchospasm or secretions. Go figure, right? Go figure. All right, the thoracentesis, this can be therapeutic. There's lots of fluid that's crushing the lungs from inside the pleural space. Obviously, we can go ahead and remove some of that fluid that's crushing the lungs. So diagnosis, we already talked about this. If it's a community-acquired pneumonia, so a little chest x-ray, can be one of your big signs there. We're going to look for patchy diffuse versus lobar and segmental. We can get a sputum sample. The sputum sample will help us tell exactly what's growing in there. Yeah, that's a picture of sputum bowl if you can't tell. Sputum sample, ultimately, we can get a thoracentesis, hence why Thor is in this picture. Run that for a sample. If they have a lot of fluid in there, we need to remove that fluid that's around their lung anyway. We could just send that fluid to the lab for culture. As well, so we could do a thoracentesis. We could do a CT scan. We can also see it on a CT scan. Now, the CT scan is going to give us more definition than an X-ray, but it's more expensive, and you're exposing to more radiation. They have to lie flat for it, so there's issues there. And then finally, bronchoscopy. I know it's a brachiosaurus, not a bronchiosaurus, but we could do a bronchoscopy, get a BAL, get fluid samples, all that stuff from inside the lung to confirm the diagnosis. Not only that, but if they did have lots of secretions, the bronchoscopy might be able to help with removing some of those secretions as well. All right, last slide. What are some of the review questions here? Common lung alterations that occur with pneumonia. You tell me. There were 3 of them that I was thinking of. Okay, this patient shows up to the hospital. What would be some of the things you would see at the bedside? What would be some of their presentations? Would they be hypoxic, hypercarbic? Would they be tachypnic? Would they be bradypnic? Would they be tachycardic? Would they be bradycardic? Would they be hypertensive? Would they be hypotensive? Right? What would they look like? Would there be digital clubbing here? Would they have hemoptysis? Would there be a dry non-productive cough? Right? So this is sort of things that I want you to sort of go through. What would be the presentation of pneumonia if they showed up? What would you see? What would their X-ray look like? What would their temperature look like if it was viral? What would their temperature look like if it was bacterial? What would their ABG show if it's mild? What if it's severe? What would their ABG show? Could it be a mixed acidosis on top of anything else? Could it be just a respiratory acidosis by itself? Would it be a respiratory alkalosis if it was severe? What type of condition is this? Is this shunt-like? Is it dead space? What would happen to their DO2? What would happen to their O2-ER? What would happen to their venous saturation? All right, on this process, remember this is not obstructive, this is restrictive. What would their PFTs look like if you were to do a PFT on this pneumonia patient? What would be their volumes? What would be their flow rates? Anything abnormal about their sputum? You did a sputum sample on them. Would there be anything abnormal? Would it present abnormally? Would it be a different color? Would it be pus-like, like purulent, or would it be mucoid? What would lab tests show, right? What would you see on their labs? Okay, so this patient shows up with pneumonia. Recommend a therapy that would help them with their pneumonia. That would help them get their oxygen levels back up. Recommend a therapy that's going to help them get better. Not only that, but here's a bonus one. Recommend a therapy that would help prevent someone from getting a pneumonia while they're in the hospital. All right, hopefully you got those all down.